Hello, I welcome you all. Myself, Dr. VIKAS BASA. I'm a consultant pediatric orthopedic surgeon at Kokilaben Dhirubhai Ambani Hospital in Mumbai. I thank Dr. Tarun and IFICS for giving me this opportunity. The fractioning femurs in children are very rare. They constitute only 1% of all the pediatric related fractures. Having said that, in developing countries, it becomes unavoidable to treat these delayed and neglected cases because of the ignorance and not receiving the medical help on time. So during my fellowship in pediatric orthopedics, I was told, let the sun not rise on a child with fractured neck femur, meaning reduce and stabilize the fracture before the child sees the next sunrise. So when the fracture is not reduced for more than 24 hours, it is termed as a delayed neck of femur fracture. And when no treatment was given for more than 1 month, it is termed as neglected femur neck fracture. So this fracture has got a very narrow window period. So we need to address the fracture in time to avoid devastating complications. So every treating orthopedic surgeon is concerned, is worried of this fracture. Why? Because the proximity of the femoral epiphysis, the vulnerable blood supply, and the tremendous forces acting across the joint are the prime reasons for making this fracture uh, to have more complications like vascular necrosis, non-union, development of coxa early proximal fascial closure leading to the limb length discrepancy, and chondrolysis of the cartilage, ultimately having degenerative secondary osteoarthritis. Having these complications is very devastating for the rest of their life, so better avoid them and treat them early. So this paper is from Radish Children's Hospital. It's a systematic review. It was published in Bone and Joint Journal. One of the authors is Dr. Harish Osalkar. So they wanted to know which are all the articles available have the relevant information on the factors affecting the outcome of these fractures in children. So they studied 30 such articles and they found that delay in treatment is one of the major factors affecting the outcome. So they concluded that 4.2 times higher rate of AVN was noted when definitive treatment was delayed for more than 24 hours. So Dr. Azam and his colleagues published their work in Indian Journal of Orthopaedics. They studied type 2 and type 3 deltoid fractures, which are displaced and presented late. So in their study, they had 22 patients. The mean delay in the treatment was 11.2 days. In 22 patients, 14 underwent closed reduction and 8 were treated with open reduction. The mean follow-up of these cases was 5.9 years, which is actually a good follow-up. And they found that in the operated cases, the rate of AVN was 22% in the cases which were treated in the first week, and 46.1% rate of AVN was seen in cases treated in the second week. And those cases which are treated in third week, almost they had 60% of AVN. So they concluded that when surgery was delayed for more than 48 hours, the complications were higher. And further, they observed that the rate of AVN progressively increased from first to the third week. So this paper is from Journal of Pediatric Orthopedics by Dr. Lee Ju. Uh, they studied almost 58 children. And their sample size was high among the articles which I reviewed. So all cases were delayed fracture neck femurs, and it is a retrospective study. They compared closed reduction versus open reduction. The average delay in the treatment or the surgery was 4.67 days. And all the 58 patients underwent closed reduction, and open reduction was performed only after 5 failed attempts of the closed reduction. And they followed up these cases for almost 3 years. And they use this Ratliff criteria to assess their outcome. And in fact, when you come across any paper which is dealing with delayed and neglected cases of fracture-neck femur, almost everybody compared their results using this criteria. So what is this criteria? So this Ratliff description has the results formulated as good, fair, and poor according to the clinical and radiological outcome of the fracture union and the movements of the hip and the activity of the child in day-to-day practice. So they assess the results in terms of quality of reduction, whether the fraction was anatomically reduced or was it an acceptable reduction. What was the time required for fracture union? And the percentage of the fine results according to the Ratliff criteria, which I just stated. And what were the incidence of complications and the follow-up? So in the summary, they quoted that the avascular necrosis was significantly lower in those fractures which were anatomically reduced and those fractures which were treated by method of open reduction. And those treated early and in Delbert type 3 and type 4 fractures, they saw significantly lower rate of ABN. And the development of coxa vara was less in cases treated with internal fixation. Only one case they had a non-union from closed reduction group, and they found no cases of non-union in open reduction group. So Dr. Magoo has an extensive work on neck of femur fractures in children as well as in adults. He studied and published various osteotomies around the proximal femur. And this article he published in Journal of Trauma in 2007, in which he had 10 cases, all were neglected femoral fractures. Everybody presented after the period of 1 year, and some of them even landed up with a non-union fracture femur. So he followed up them for almost minimum period of 5 years. It's a retrospective study with it's a prospective study with a retrospective analysis. And he evaluated the role of modified Powell's intertrochanteric osteotomy in children having neglected femoral fractures. He beautifully explained the technique in this paper, and an extensive preoperative work has been done. And the preoperative X-rays tracings was done, and the fracture angle, the Powell's angle was calculated, and this intertrochanteric osteotomy line is defined, that is B to C, and a Y-shaped intertrochanteric wedge was taken, that is 20 degrees of Y-shaped intertrochanteric wedge was taken, that is CBD, and a chisel was passed through a trochanteric line, that's landmark area, that is A, which is parallel to the shaft of the femur, but at an angle of 80 degrees with the rest of the chisel. And then the angle, the blade plate was inserted through this angle, and then the distal fragment is abducted and then fixed with a plate and screw. So this was a case of neglected femoral fracture having non-union, and after the modified Powell's intertrochanteric osteotomy, at 20 weeks it showed good healing. There was no collapse of the femoral head, and the neck shaft angle was restored to 135 degrees. And at 12 years follow-up, still there are no signs of ABN, but the joint space is reduced. This child had a 1 centimeter shortening, which he stated in his paper. So he concluded that modified Powell's intertrochanteric osteotomy creates a biomechanical environment which is conducive to the healing of the fracture neck femurs which were neglected, and simultaneously it corrects associated coxa vara. And he also stated that it creates it has a biological role in restoring the viability of a non-collapsed head. So this paper was published in Journal of Child's Orthopaedics in 2017, and this paper is from Egypt by Dr. Ilkidi and Negeri. So they used a fibular stud graft in a case in a fracture neck femur who had established non-union. So they evaluated the clinical and the radiological outcomes using this fibular stud graft as a fixation device with and without subtrochanteric valgus osteotomy. So in their study, they had 12 children who had non-union of fracture neck femur. The average age of study population was 8.2 years, ranging from 5 to 15 years. So in 6 cases, they used fibula strut graft plus subtrochanteric valgus osteotomy was done. And in remaining 6 cases, they used fibula strut graft alone with hip spica. The mean follow-up of their study was almost 2 years, 20.4 months. So this was a case example in which after the initial fixation with the screws, there is a non-union, there is a collapse of the femoral head, and the neck shaft angle was less than 110 degrees. And after the surgery, this is X-ray of immediate post-op using a fibula strut graft, and they did a subtrochanteric valgus osteotomy and fixed with a contoured plate. So the neck shaft angle is restored almost to 130 degrees in this case. And in another, this example from the another case group in which there is a well-established non-union of the neck of the femur fracture, and they treated with a fibula strut graft and hip spica, and no valgus osteotomy was done. And if you see, the fibula graft is well fitting and it is acting as an internal fixation device. So they said that fibula graft provides a sufficient osteoconductive and osteoinductive potential, and it adds to the rotational stability as well, and it helps in revascularization of the non-union part of the neck of femur. And the valgus osteotomy acts as a biological stimulus for healing of these fractures, and it promotes an osteogenesis as a result of converting the shearing forces to the compressive forces across the fracture site. So there are multiple publications. This case report by Dr. Nirmal Raj from PGI Chandigarh, in which he had a 10 years old boy with a bilateral neck of femur fracture. After the fixation, he presented with a slipped capillofemoral epiphysis, so which was very rare and unusual. And after fixing this capillofemoral epiphysis, it healed well, and the child did almost normal. So the fractured neck femurs are also seen in special conditions like cerebral palsy. Though it's a special condition, the method of treating these fractures remains the same. You have to address them in time and with appropriate method of treating them. And there is a prospective multicentric therapeutic study from Odisha about the femoral neck fractures. There are multiple papers available. But the learning points here are, whenever you have these fractures, treat them early because it's a fracture of necessity, and reduce these fractures anatomically, and use the fixation devices whenever necessary to avoid the collapse and to maintain the reduction. And like Dr. Magoo described, the valgus intertrochanteric osteotomy plays a very good role in restoring the vascularity, and adequately immobilize these fractures for about 6 to 8 weeks in hip spica, and then gradually mobilize them. And do have a long follow-up to note any complications and treat them whenever there is a need to address them. So thank you and stay safe.